Dissociative amnesia is a psychological disorder. Look at these pictures. Life, stressful events, and neural brain imaging for diagnosis. Look at this MRI, CT. A detail going on. Introduction. Dissociative amnesia is a psychological disorder characterized by an inability to recall important personal information, usually related to stress, trauma, or psychological conflict. Unlike ordinary forgetfulness, this condition cannot be explained by typical memory loss such as aging or brain injury. It is classified under dissociative disorders in the DSM-5 and often coexisting with anxiety, depression, or post-traumatic stress disorder. Definition. Dissociative amnesia is defined as the inability to recall autobiographical information, usually of a traumatic or stressful nature, that is inconsistent with ordinary forgetting. Etymology. Dissociative from Latin dissociare to separate, referring to disconnection between thoughts, identity, memory, and consciousness. Amnesia from Greek amnesia, forgetfulness, meaning loss of memory. Epidemiology. Lifetime prevalence about 1 to 3 percentage of the general population, more common in women than men. Frequently associated with childhood abuse, combat exposure, or natural disasters. Onset usually in late adolescence or early adulthood. Type, types 1. Localized amnesia, inability to recall events during a specific period. 2. Selective amnesia, can recall some but not all events during a certain time. 3. Generalized amnesia, complete loss of memory for one's life, history, and identity. 4. Continuous amnesia, inability to form new memories from a certain time onwards. 5. Systematized amnesia, memory loss related to a specific category, example family or a specific event. 6. Dissociative fog, sudden travel or wandering away with inability to recall past, sometimes adopting a new identity. Causes: 1. Severe psychological trauma, example abuse, accidents, combat. 2. Exposure to natural disasters or war. 3. Interpersonal conflict, overwhelming stress. 4. Coexisting mental disorders, PTSD, depression. Risk factors: childhood trauma or neglect. 2. History of physical, sexual or emotional abuse. 3. Family history of dissociative disorders. 4. Personality traits: suggestibility, high fantasy, pruniness. 5. Severe stresses such as loss, disaster or violence. Complications: 1. Impaired social and occupational functioning. 2. Relationship problems. 3. Co-occurrence of depression, anxiety, PTSD or substance abuse. 4. Increased risk of self-harm or suicidal behavior. Pathophysiology: pathophysiology of disassociative amnesia, step by step. 1. Traumatic stressful events occurs. The individual experiences overwhelming psychological trauma, example abuse, combat, disaster. This event generates extreme emotional distress. 2. Activation of stress response. The hypothalamic pituitary axis (HB axis) is activated. Stress hormones, mainly cortisol, are released. The body enters a fight, flight, or freeze state. 3. Neurobiological disruption of memory processing. Amygdala becomes overactive, amplifying fear. Hippocampus is suppressed by high cortisol. Memory formation is blocked or fragmented. Prefrontal cortex, responsible for rational control and retrieval of memory, becomes underactive, impairing conscious recall. 4. Disassociation, defense mechanism to protect the individual from intolerable trauma. The brain disconnects consciousness from memory storage. The memory is not aroused, but it is inaccessible to conscious awareness. This creates a psychological compartmentalization of memory. 5. Formation of amnesia. The traumatic memory is stored in an unconscious or disassociated form. Ordinary autobiographical memory recall is disrupted. Gaps in memory appear. In some cases, this leads to dissociative fog, sudden travel with identity confusion. 6. Persistence of memory block. Memory remains unavailable until psychological stress is reduced or therapeutic interventions are applied. Sometimes memories return suddenly, spontaneous recovery, or gradually through therapy. Summary flowchart: trauma, stress response, HB axis, cortisol surge, hippocampus suppression plus amygdala overdrive plus prefrontal cortex underactivity. Disassociation defense. Memory blocked from conscious axis. Dissociative amnesia. Signs and symptoms. 1. Inability to recall important autobiographical information. 2. Sudden memory gaps related to traumatic or stressful events. 4. Confusion or distress about memory loss. 5. In severe cases, wandering or fog states. 6. Emotional symptoms: anxiety, depression, shame, or detachment. A diagnosis, medical diagnosis. 1. History and clinical interview. 2. DSM-5 diagnostic criteria. 3. Rule out neurological causes, seizures, brain injury, dementia. 4. Neuroimaging, MRI, CT, and EEG to exclude organic causes 5. Psychological assessment. Structured clinical interview for dissociative disorders. Nursing diagnosis. 1. Disturbed personal identity related to memory impairment. 2. Ineffective coping related to psychological trauma. 3. Risk for self-harm or suicide. 4. Anxiety related to memory gaps and confusion. 5. Social isolation related to impaired memory and functioning. Medical management. 1. No specific medication for dissociative amnesia. 2. Pharmacological therapy may be used to treat comorbid conditions. Including antidepressants, anxiolytics for severe anxiety, 3. Adjuvant use of hypnosis or sedative medications in controlled setting to facilitate memory retrieval. Nursing management. 1. Establish trust and therapeutic relationship. 2. Provide emotional support and reassurance. 3. Maintain safety. Prevent self-harm. 4. Encourage expression of feeling in a non-judgmental environment. 5. Collaborate with mental health team for therapy. 6. Educate patient and family about the condition. Treatment options. 1. Psychotherapy, mainstay treatment. Trauma focused. Cognitive behavioral therapy, CBT. Psychodynamic therapy. 2. Hypnotherapy may help recover repressed memory. 3. Eye movement, desensitization and reprocessing for trauma. 4. Group therapy and family therapy. 5. Medications for associated depression, anxiety or insomnia. Psychosocial medicine. 1. Cognitive behavioral therapy, correcting distorted thoughts and coping strategies. 2. Supportive counseling, reassurance, validation and stress reduction. 3. Family therapy, improving communication and family support. 5. Social skill training, rebuilding interpersonal relationships. 5. Community support groups, reducing isolation and providing shared experiences. Prevention. 1. Early intervention after traumatic events. 2. Promoting resilience and coping strategies. 3. Supportive family and social environment. 4. Education on stress management techniques. 5. Reducing stigma and encouraging mental health awareness. In conclusion, dissociative amnesia is a protective yet disabling psychiatric condition often triggered by trauma and overwhelming stress. Although it does not result from organic brain damage, it significantly impairs memory, identity, and daily functioning. A combination of psychotherapy, supportive care, and treatment of comorbid conditions can help patients recover and lead fulfilling lives. Early recognition and intervention are crucial in preventing complications and promoting long term recovery. Thank you. Have a nice day.